Right, so I think the last lecture, we kind of left it off with left atrial enlargement. Just to remind you that there is this double density sign that you can see on the image over here, with the red being the border of the right atrium and the lilac curve being the border of the left atrium, because it's just gotten that big. Now we also went through the cause as well, most commonly left-sided valvular defects. Obviously, in this case, you can clearly see that there is a mitral valve problem because you can see the replacement over there. So the next thing that I want to go into is this. Now, what can anyone tell me what they see over here for starters? Just pop it up in the chat box. Yeah, it's a big heart. Yep, there's definitely cardiomegaly, but can anyone identify anything more about it? Can someone describe me the features of what they see? So for instance, let me start off by saying that the mediastinum looks a bit wider than normal. Anything else? Any other obvious features that we can see over here? Right. Okay. So the point I'm trying to make is that there aren't any specific features. And if there are any, you're an amazing radiologist if you're able to spot any. Now this is a PA radiograph of a right ventricular enlargement. Now the reason why it's right ventricular enlargement becomes more apparent because, so first of all, let's just start off with the cause of right ventricular enlargement. Can anyone tell me some cause of right ventricular enlargement? Shout them out, put them in the chat box, whichever. Yeah, okay, fine. Anything else? So, yeah, COPD, well done, yeah. Anything else at all? Yeah, that's fine. So by intrinsic right ventricular disease, most commonly it would be any congenital disorders, like something that comes into mind is tetralogy of Fallot for sure. Something else that might be caused by it's a secondary cause, I guess, in many cases would be viral myocarditis that can then subsequently develop into dilated cardiomyopathy. Of course, you've got the classic things like atrial septal defects, ventral septal defects. So these are all hereditary conditions. And as you rightly mentioned, Amir, as well, we also have the PV stenosis or pulmonary hypertension. There we go. PV stenosis. Exactly. Well done, Sarah. Right. Okay. Now, the main thing is that we have to always correlate this, well, when we're suspecting something like this, and when we see a big heart, we can't automatically assume it's right ventricular enlargement, because for all intents and purposes, that can just be classic heart failure that has caused the heart to become so big, and it might be mainly to do with the left heart instead. Or another possible cause itself can be that that looks more and more like a pericardial effusion as well. So you have to always correlate this stuff with the ECG. Now, what can an ECG show? An ECG usually, from my knowledge, you will definitely have right axis deviation. You also have deep S waves in the lateral leads as well. I think those are the main important features that you need to look for. So when you are given an X-ray like this, don't just automatically assume, okay, you know what, it's pericardial effusion, it's cardiomegaly, must be heart failure, and so on and so forth. Always correlate it with the ECG and always correlate with the clinical picture as well. It's one key thing. Now, the problem with using just a PA view to see a right ventricular enlargement is that it is not seen clearly. As I mentioned, you have all these other differentials that you can, and generally speaking, as a junior doctor, you looking at a chest X-ray, you should try and narrow down the diagnosis a lot further than coming up with 5 or 6 different possible conditions. So that's why clinical correlation is important. But even so, the general PA criteria for right ventricular enlargement is these two things. You have this rounded left heart border, and you have this uplifted cardiac apex. Now, in addition to the cardiomegaly as well. Now, let's just go look at that again. you can see over here that there is definitely a rounded left border. And you can also see the cardiac apex, the tip of it is actually raised a little bit up from above the diaphragm. Okay, but in my opinion, that isn't, and it's the same with many of the radiologists I spoke to as well. It's not really a very conclusive way of defining that this is definitely right ventricular enlargement. For all intents and purposes, like I mentioned, it could be just pericardial effusion, it could be some sort of heart failure, it could be left ventricular failure as well. It's causing all of these things. So what is a key thing? The key thing is always request a lateral view. And believe me, you will solve a lot of problems if you're able to request this lateral view, because this would be a normal lateral view chest x-ray. You can see how the retrosternal space, let me try and get the annotate up, there we go. There we go. So you can see that the retrosternal space is completely empty over here, which is a normal thing. Okay, it's just filled with some fluid. You have the actual heart over here, but there we go. So you can see over here that in right ventricular enlargement, that retrosternal space is completely filled out. So that is a very key defining point that I'm trying to make. In a lateral, you can clearly see this specific feature. Okay, right, let's carry on. So that was all to do with that. I think that's something I left over from last lecture. So pericardial effusion. First of all, as we mentioned before, it is very, very hard to distinguish pericardial effusion in normal chest x-rays as well. Now, before we go into it any further, so yeah, I mean, before we mentioned as well, it's an enlarged silhouette as well. Hang on, Amir just asked me a question. Let me just answer that question at the end, Amir. Is that okay? So the main finding with all cardiac causes anyway is just the enlarged silhouette. You have to always clinically correlate them as well, okay? And the main thing is there's a lot of causes. Can anyone tell me a couple of the causes of pericardial effusion? Just shout them out at me. So the way I like to divide them is between acute and subacute. There are some that are very acute, and there are some that are subacute. So you mentioned pericarditis. Would that be acute or subacute? Yes, it's acute if it's viral pericarditis. It's more subacute if it is bacterial pericarditis. Could also be chronic, exactly. And the viral can then split into chronic as well, exactly. MI for sure, that's an acute. Yep, exactly. And there's also a lot of iatrogenic disease as well. So for instance, if you were to do a right ventricular biopsy, or if you're doing any kind of electrophysiological procedures as well, you're forgetting the obvious, which is just general trauma. Trauma can cause it as well. It can result in a cardiac tamponade being formed as well. Can anyone tell me the chronic causes? Yeah, okay, autoimmune disease as well, yeah. What other chronic causes are there? Common is common, but yeah, okay, I'll give you that one. Yeah, cancer, exactly. I was going to say any malignancy can lead to pericardial effusion for sure. And remember, something that you're always forgetting is that you have to link systems together. Cardiovascular, yeah, radiotherapy can also cause it, but cardiovascular, renal, and respiratory systems are always linked together. So anything that affects one will definitely affect the other two. In particular, if there is anything to do with the kidneys, it will have an effect on the heart. So in this case, if there's any kind of renal failure, you will see pericardial effusion, okay? Right, now, there are two signs to look out for that are very, very important. So I'm gonna take them through. I'm gonna take you through them. So first one is this. So this is a classic representation of pericardial effusion. Now, anyone know what sign I'd want to discuss over here? Can anyone relate what that heart looks like? Does anyone want to try and guess what that heart looks like? To be honest, I really don't agree with the sign at all. I mean, for me, it looks like a Scottish bagpipe. Yeah, yeah, Sarah, I don't know what you think a bottle is, but apparently this is known as a water bottle sign. And when I found out more and more about it back then, this was apparently a water bottle. So I have no idea who drinks out of this kind of water bottle, but this is the classic water bottle sign that you're meant to be looking for. Okay. Now, the second one is a little bit better. Now, what can you see over here? What is a very, very distinctive feature that you can see over here? So this is a lateral view, and you always have to look at the lateral view, like I mentioned. What is a very distinctive feature that you can see over here? Okay, fine. But retrosternal space being gone could only, it would be for right ventricular enlargement. But there is another specific sign over here that is quite unique, and it's pathognomic for pericardial effusion. The increased AP diameter would not necessarily be pathognomic for pericardial effusion, but rather you'd only be looking out for if there is any clinical again, it's cardiomegaly that could cause a round heart shadow as well. Let me just kind of zoom into what I'm talking about. So this section is zoomed in from the lower part of the heart, from the lower anterior portion of the heart, okay? Can you see something specific over here? I'm gonna try and give you a bit of a drawing as well. It's this that I'm looking for, okay? Does anyone know what sign I'm referring to over here? This is something that I've seen. Oh, no, no, no. It is definitely not air. It's definitely not air. Remember, nothing that dense can be air, and nothing. Exactly. It is. Well done, Sarah. It is definitely the Oreo cookie sign. Now, for extra points, does anyone want to go through the 3 different layers? So let's start off with the posterior layer, the black line, the posterior black line. What do you think that is? Anyone? Pericardial space. Okay, let's go through it. What appears black and what appears white? So by that I mean, what do the black areas in an X-ray show, and what do the white areas in an X-ray show? Just to sum up really quickly, black areas show areas of low density. Exactly, low density. And white areas show areas of high density. Now, typically speaking, low dense structures are ones such as air, water, or in this case, it could be another area of tissue, fat tissue perhaps. Okay, so the posterior black line would indicate pericardial fat. Okay, the middle brightening that you see there, that would be the actual effusion itself. Okay, because that effusion could be transudate, could be exudate, but the point is that you have this idea of the pericardial fat being separated off from the epicardial fat, which is the last layer, the most anterior layer that you can see. That most anterior layer, that most anterior black strip that you see, that would be the epicardial fat. Now, typically speaking, in normal individuals, you will not be able to see that white space in the middle because there is no effusion. There is a very, very thin layer of fluid that is just to provide to provide some kind of lubrication to prevent any friction between the two sacs. But ideally speaking, you should not be able to see this at all in a normal individual. So, and for anyone who does not know what an Oreo cookie looks like, this is what an Oreo cookie looks like. As you can see, there's black, there's white, and there's black again. I'm not going to ask you to, know how to eat one. I should hope that you know how to eat one. Right. Next thing I want to talk about is a widened mediastinum. So we always measure the width. Now, the reason why we measure the width is because there are a lot of issues in terms of quality when we come to, thank you. There's a lot of issues when it comes to quality when we're thinking about a widened mediastinum. I'll get into that as well, but typically what we define radiologically as a widened mediastinum is any mediastinum that is over 8 centimeters in width. Okay. We always have to rule out there's any kind of quality issue. And by quality issue, I mean, so first of all, can anyone tell me what I mean by quality issues? What can affect the mediastinum's width? We've already seen this before from my first lecture about what aspects. Over under exposure for sure, yep. Exactly, how much the patient inspired. What can you tell me as to what you mean by that? So what happens if the patient is inspired too much? If they inspire too much, will it look too wide, do you think? Think about it. If I'm breathing in all the air and my lungs are full of air, wouldn't that squash the mediastinum and make it look more narrow? There we go. Exactly. So by this, I just want to highlight that it usually is when the patient is not cooperative and therefore they're not actually inspiring enough. And the last thing is the rotation as well. The rotation, we've already seen how rotation can affect the heart size. The same rule applies for the mediastinum. So any that will cause a change in the rotation, if they're not straight, it'll make the mediastinum look wider. The reason why is because heart is part of mediastinum. So therefore, anything that changes the size of the heart on the plane film will definitely have an effect on the mediastinum. Now, I know that you've seen many different ways of separating the mediastinum. I know that there is one method where there is an anterior, superior, anterior, inferior, then there's a middle, and there's a posterior mediastinum. This is the one that I like to use. The reason why is because I can kind of clearly note the different areas anatomically, and the main thing is I can relate to it in terms, I can even find out exactly where it is based on the physical examination of the patient. So typically speaking, the superior mediastinum is the one that is above the angle of Louis. Now the angle of Louis is just simply another word for saying the sternal angle, where the superior part of the sternum and the part of the sternum meet. Okay, so that's the superior mediastinum. Over there, we generally be only focusing on the aortic aneurysms. Sorry, hang on, I think my light's too bright. There we go. Aortic aneurysms. Then we have the anterior mediastinum. The anterior mediastinum is just basically the space that is in front of the heart, so anterior to the pericardium, and it's still below the sternal angle and immediately retrosternally. Okay, so this is the anterior mediastinum. Now, can anyone tell me as to what kind of pathologies might actually occur in the anterior mediastinum, based on anatomy, based on what you know about what structures there are over there? What kind of pathologies might you expect to see in the anterior mediastinum? Good. Thyroid, thymus, well done. Anything else at all? Those are the common ones, exactly. Remember, we're talking the anterior mediastinum. There is no airways there. The airways are all in the lungs. If you find an airway in the mediastinum, not at that level. So another very, very common diagnosis is a lymphoma. In fact, it is so common that you can find it over there. Yeah, cancer. I know that you asked for cancer a lot last lesson, so here we go. Here are all the cancers coming up. So lymphoma is actually very common, that because you can spot the pathologies more clearly. Okay, so next we have the middle. The middle mediastinum, as you can see, is just bordered off by the anterior and posterior mediastinum. And the superior, you have the sternal angle sternum. Now the middle mediastinum, its contents are something that you should know. So you have the actual pericardium itself, including the heart. You have the several different lymph nodes. If I remember correctly, you have the subcarinal lymph nodes. You have the paratracheal lymph nodes. I believe you also have the hilar lymph nodes over there, because the hilar are given off at that level. And of course, you have the esophagus going down as well. Okay, So this is what I mean. So when you mention that there might be airway pathology in the anterior mediastinum, no, there can't be, because the trachea bifurcates way top, and it kind of splits up into its hilar, or the bronchi, much more superiorly. Okay, now what can possible pathologies be over here be? So we've got so many lymph nodes. So any kind of lymphadenopathy is definitely pathology. The aorta is in very close relation here. So there might be any aortic aneurysm or coarctation, anything to do with the aorta can cause or can show up on this point. There can be several different cysts. The most common one is a pericardial cyst come up over here. Pericardial cysts are usually just due to repeated pericarditis causing a change in the actual connective tissue around the pericardium, causing it to develop a sort of a cavity like a cyst, and that'll just grow and grow as fluid increases its volume over there. Finally, I guess when it comes to gastroenterology, a couple of things would be the dilated esophagus, and in very rare cases, a hiatus hernia can also be seen very clearly in a lateral view like this. Finally, we have the posterior mediastinum. The posterior mediastinum itself, it's just the back of the pericardium all the way up until the spine. So by that, I mean the prevertebral as well as the perivertebral spaces. Not really much in terms of pathologies over here. Anything that is to do with pathology over there would stem from an extension of spinal masses, or if there is any neurogenic tumors. By neurogenic tumors, I mean if there is any primary neurogenic tumors to do with the neural tissue, pure nerves, or neural connective tissue as well. Okay, so masses, those are the main things that need to be concerned about when it comes to the mediastinum. As we've mentioned before, the location of the mass, so which area of the mediastinum is affected, will give an idea of the possible diagnosis. Now, again, I have to mention, always clinically correlate. So let's have a look at a couple of things. So we have a case, okay? So we've got a 47-year-old female with neck swelling. This neck swelling has been increasing in size rapidly in the last 2 years. She comes into you, she saying that she's got palpitation, she's got breathlessness on exertion, tachycardia, some hand tremor. Her past medical history is just some diabetes and hypertension. They're both under control. What would you do? What would the management, what would the investigations? Don't just immediately guess. You can start to think, but always try and see what you have to investigate, because this might not necessarily be thyroid. Okay, but what investigation would you do to confirm it? What would you do? Okay, TSH, but that so you're getting into the habit of immediately going down with whatever it is that you think, but you still don't know enough information. Yes, clinically you've kind of found out about this in terms of history taking, but the point is you're still meant to do all your investigations to cement what it is that you think. So in terms of investigations, yeah, ultrasound as well. Remember, we're not going to radiology just yet. We have to always clinically correlate it based on lab results as well. So first thing I do is chest x-ray, bloods, ECG. ECG for sure. Why? It's because of tachycardia. But in the bloods, yes, of course, you can do all the thyroid function tests. You have to do the full blood count. You have to do using ECG. You have to do CRP at this point. Okay, you have to do everything at this point. Only on this can you then think about a CT. You can then think about, because at this point you don't know, you can't even rule out if this is thyroid carcinoma. If it is thyroid carcinoma, you have to do a CT to see if there's any Mets. At the same time, because she's saying that she's got neck swelling, you do have to do a laryngoscopy to see if there's any compromise of the airway. And if at all, it is an external swelling that is pushing down into the airway, or if there is an internal swelling of the airway that is then pushing outwards. Okay, and then finally, if you've done all of these to finally nail it, you have to do a final aspiration cytology just to make sure that you are dealing with what it is that you think that you're dealing with. So this is what the X-ray shows. Now, what can you tell me about this X-ray? Yeah, tracheal deviation. So that definitely points towards the fact that her breathlessness is well, she's not making it up. Let's put it that way. Why is it deviated? Can you spot it? Can you spot the pathology? Yep, it's pushed away. Yep. And you can see the pathology as well. You can see the pathology very, very clearly. Yeah, there's a mass on the left, and that is what's causing it. That's exactly what's causing it. It's right here. This huge mass over here. Above the aortic knuckle. Well done. Good terminology. Right. So in this case, we are dealing with a multinodular goiter. Okay. And the fact that she's reporting tachycardia, the fact that she's reporting breathlessness and so on, we may even have to assume that at this point it is a toxic multinodular goiter, and we have to do an FNAC, and that will then show us exactly what's going on. Wow, okay, that's not something we routinely do on a daily basis. The NHS is not that well funded, but yeah, we can definitely do that. And of course, an ultrasound scan to confirm everything as well, just to see if it is thyroid carcinoma or if it's just a toxic multinodular goiter. Right, second case. This one's a bit more interesting. This is the one that I actually personally had to deal with, and I was quite shocked as well. So we have a 27-year-old female, flu-like symptoms. She had swelling in the left side, supraclavicular region of the neck. No past medical history or recent histories, no family history. She wasn't really sure if there was any kind of weight loss. She's saying that she's been eating quite well, but there is no weight gain. Now, you'll find this across so many different people, especially with the elderly, especially with the middle-aged. They will not know if they've been having weight loss if they're eating a lot, okay? If they are unsure if they're having weight loss, always assume there is, okay? Because yep, could be lymphoma. Okay, so she does have mild fever. She does not know whether there's any sweating. She does not know whether there's anything else, but she does have mild fever. This is all that I was given at the start. So yes, like Emir said, I thought it might be lymphoma, but I thought, you know what? Let's be thorough about this. I did a physical. The physical examination revealed sort of hard lymph nodes. They were fixed. The way I palpated, I only felt it in the left supraclavicular area and lateral cervical area. No shortness of breath, by the way. Well done, good one for asking that, but there's no shortness of breath. Just classic flu-like symptoms. So she wasn't really tachypneic, she wasn't really dyspneic, but she was struggling a little bit. Okay, right. What investigations would you do? Let's start the basics. I mean, you know, you have to always clinically correlate everything. There has to be like a method. So what would you do at the start with this lady? Okay, fine. So what investigations would you do? General blood counts. Okay, so the first thing that I would do is definitely do all of these, the basics: full blood counts, liver function tests, CRP, user needs. And think about a blood film as well, particularly if I'm thinking that, okay, there might be an element of leukemia here as well, along with a lymphoma. I could do a blood film to see any kind of blasts if I want to. At the same time, because she was reporting the way she was, I thought it would be very, very good if I do an LDH, because an LDH is very, very typical in lymphoma. It'll be raised, as well as a serum electrophoresis. We should do technically an ESR, but ESR is very, very unspecific. It's not specific at all. It could be full things, autoinflammatory disorders, classic inflammation, can be raised even in lymphoma. So it doesn't really narrow it down. But because of the way she was presenting, I thought, and because she's young, okay, she's young, she's got her whole life ahead of her. So I thought I'll be even more safe. I did EBV as well. No family history at all. I did EBV as well. I did toxoplasmosis, HIV. I did all of these as well. Then I requested an ultrasound, and then I requested a chest X-ray. And if I want to develop on that in the future, I can then book a CT. Okay, so this is the kind of methodology that you should be thinking of. Okay, you have to go in stages. It's a good thing to know what your diagnosis is and what you're thinking of in terms of differentials. But remember, always have differentials and always request investigations and management to cover every single differential and narrow it down. Okay, that's the methodology that you should follow. Right. Bloods, they just showed elevated neutrophils, elevated CRP, and the ESR was elevated as well. Elevated neutrophils, elevated CRP. What are we thinking immediately if neutrophils and CRP are elevated? Just those two. Inflammation. Exactly. Could be something else, but for me, the main thing is elevated CRP, elevated neutrophils is inflammation. Neutrophils were in the 13,000, so that's definitely an inflammation. CRP was in the 70 something, if I remember correctly. Right. The ultrasound showed that there was 2.5 by 2 centimeter nodules. So exactly the where I examined her as well, it showed these kind of nodules. Now, what do you do after that? After that, an X-ray was done, and this is what the X-ray showed. Okay. And anyone want to guess what this is now? I think Amir would be very happy. There we go. It is definitely an lymphoma, and this was a big shock because the lady was just 27 years old, and I had to break the bad news to her, saying that she does have lymphoma. Anyone want to guess what kind of lymphoma? What kind of lymphoma would affect typically younger individuals? Yep, exactly, non-Hodgkin's lymphoma. I don't want to go into the specifics of it because, to be honest, I really don't remember what the blood film and the cytology showed after that. Right, what do we have over here? First of all, does anyone want to tell me how good the quality of I knew Amir would definitely pick up on that. Yes, and that's actually one of the things I want to talk to you about as well. This X-ray is of brilliant quality. At the same time, it is also measuring the density so well of the breast. So in this case, I would definitely also think about reviewing the woman's history of mammographies as well, because they are very dense. Okay. Now, in this case, what kind of pathology? You can clearly see there's a mass on the left side of the heart, left side of the mediastinum. Yeah, the stomach is where it belongs. So you can clearly see there's a mass. Now, anyone want to guess whether it's anterior or posterior? Where would it be? Yeah. So if there's a clear cardiac silhouette, it's more likely to be posterior. So here we go. Okay, so this is a lateral view of the same woman. Okay, and you can see that there is a definite posterior mass in her mediastinum. Anyone want to guess what this can be? Remember, in terms of differentials, what were we thinking for posterior mediastinum? We're thinking of something to do with the spinal extensions, neuroblastomas. Neuroblastomas are more common in children. Exactly. Yeah. Okay. So it is definitely a neurogenic tumor. In this case, because it is so well defined, you have to think about neural connective tissue tumors. Most likely, this is a schwannoma. Anyone know what a schwannoma is? There we go. Exactly. Schwannomas. So schwannomas are basically just malignancies that, or they're benign tumors typically that come up in the Schwann cells of the peripheral nervous system, not the central nervous system, peripheral nervous system. Okay. Right. What do we see here? What is really strange about this X-ray? Get the pointer out as well. Yes, there is a heart. Just because it's vertical doesn't mean that there's anything wrong with it. Main things that you need to look at over here are these features. Look at how defined they are. What are these features? What are these things? What is usually over here on the left and on the right over here? What do we call these areas? The hilar, exactly. Now, this is a case of hilar enlargement. Okay, this is a clear-cut case of hilar enlargement. Yes, I mean, there's so many different diagnoses. Do you want to go through a couple of the causes at all? Remember, it is a very non-specific sign. There's so many different possible diagnoses that we can come up with. I like to split them up as infectious, malignancies, and all the other miscellaneous ones. So in terms of causes, can anyone tell me infectious cause of hilar lymphadenopathy? Just to start off with. Yep, TB is definitely if you don't say TB, yep, that's for sure. Anything else? And fungi, exactly, good. So what are we thinking? I think there's histoplasmosis. There's a really funny one, coccidioidomycosis. I think I said that right or wrong, I don't know. And yeah, there we go, histoblastic, exactly. Aspergillus as well, well done. And you have to also think about some of the virus as well. So for instance, EBV as well. They can definitely cause hilar enlargement as well. Now, any malignancies, what malignancies are we thinking of here that can cause hilar lymphadenopathy? Good, primary lymphomas, well done, as we've seen just before. Or a MET as well, yep, exactly. Metastatic disease can be from anywhere. So lungs, we can think of any of the breast as well, or any of the head and neck causing tumors, or if we're dealing with a melanoma as well, it could theoretically can cause hilar enlargement as well. And of course, primary lung cancers, obviously. Now comes the strange bit where it's a miscellaneous one. So miscellaneous ones would typically be, as you've already mentioned in there, sarcoidosis, primary sarcoidosis, exactly. Yeah, exactly. IgG4 related disease as well as silicosis. Everyone know what silicosis is? Yes, no? I'll take that as a yes. Yep, okay. And pneumoconiosis as well. So for instance, if you're breathing into, yep, exactly. You're breathing in too much carbon, charcoal, silicon, all of these can cause, or silicon is basically mainly due to sand dust. All of these can cause hilar enlargements as well. A couple of rarer causes would be anything that is pulmonary vasculature related, hypertension, pulmonary artery aneurysm. These are all very, very rare, but these are things that you should be sort of thinking of as well. Always clinical correlation advised, okay, whenever you're dealing with this. So what do we see over here? So we can clearly see that there is a unilateral enlargement of the hilum. We don't see. Why are you saying we don't see? Oh, okay. Now it's there. Right, okay, so we can see that there is a unilateral enlargement of the hilum on the right side. Can anyone hazard a guess as to what this might be? Have a look at the X-ray. You like, why do you think it's TB? Good, well done, well done. Yes, it is definitely more indicative of TB. So you'd be thinking that might be a Gone complex. Well done. Any differentials? Good, cancer as well. So in this one, there's a very clear mass that you can see up there, okay? That is giving a more hyperdense appearance, and that is what you generally suspect, and you have to again correlate this clinically. So for instance, if they were complaining of weight loss, if they're quite religious smokers, then you would be correlating it more with cancer. If they say that they've had a recent travel abroad, if they say they've been having respiratory distress for the past, I don't know, maybe 4 months, 4 or 5 months, then we'd be more closer to them being TB, and there'll be classic infectious symptoms as well. Okay, next thing is hilum overlay. Now, this is something that's quite easily missed out on many things. So you can clearly see that there is a bit of an overlay over here of the left hilum. Anyone want to just quickly go through what they might be thinking of over here and what might be the most common cause for a hilum overlay? and that too in this manner. I'm also going to give you the lateral. Yep, you're right. It is posterior. Exactly. So, yeah, good. Well done. Always look at the silhouette. Well done. Okay. I think after this, I think I might need to go, guys. It's already 1:45. So in this case, what we're dealing with is a saccular, could be a nerve tumor, but nerve tumors aren't really this big. They can get bigger and bigger, and they're more common in children. So in this one, we're dealing with an adult as well. So could be, but it's not likely to be. In this case, we're dealing with a saccular aortic aneurysm. And the reason why I say that is because if you look at the PA view, there is a clear, there we go, there's a clear calcification rim of the actual aneurysm itself. So in this case, we're dealing with a saccular aneurysm. So guys, I think I do have to go, and it's already 1:45. I do need to make it to my induction. Really, I can't apply enough. And we'll definitely go through them after speaking to Pritika as well. I'll hopefully finish off everything next session, and next session will be a very long one as well, because I do want to get through all of chest X-ray, go through the diffuse and focal lung process as well. And I'll see you then. I'm really sorry I have to cut it short like this. Yeah, and see you next time. Okay. Hopefully that was a little bit helpful. I'm really sorry again. Goodbye.
Hey guys, thank you for coming in today. And don't forget to fill in the feedback form. It's there in the chat box.